Welcome, everybody. If you were looking for session 153, you are in the right place. This session is Ask a Doctor Your Questions About Medullary Thyroid Cancer with Dr. Mimi Hu. Mimi Hu, MD, is an endocrinologist and professor at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Hu has served on the faculty at MD Anderson Center since 2007. Her clinical expertise is in the evaluation and treatment of patients with papillary, follicular, and medullary thyroid cancers, hereditary endocrine neoplasia disorders, and metabolic bone and mineral disorders. She is the primary investigator and collaborator on multiple clinical trials, evaluating various targeted therapies for advanced thyroid cancer. Dr. Hu has published articles and book chapters evaluating the management of medullary thyroid cancer, multiple endocrine neoplasia, bone health in cancer patients, endocrine complications of head and neck surgery, and paraneoplastic endocrine disorders. Dr. Hu is a ThyCa medical advisor. So Dr. Hu, thank you so much for being here. And I'm going to turn it over to you.
Thank you, Daria, so much for that kind introduction and for everyone willing to jump on for another session with me. So thank you for your attention and coming on again. And I do apologize again for the first session. For those people who do know me, I am very chatty, and I just end up expanding on things and don't know when to stop sometimes. So that being said, and you may also notice now I have my reading glasses. So this is what is aging me. I can no longer read things very well on my screen without my glasses. So I now have my reading glasses on to try to answer questions. So yes, we took the questions that were posted in the Q&A from the first session, and Daria sent it to me, and I just kind of lumped them in themes so that I address them in some kind of order, and then we can address some other things that are popping up in the Q&A. So first of all, a kind of a running theme is just monitoring. Like, again, imaging, when do we do other kinds of images and everything? And specifically, one of the questions was, can medullary thyroid cancer spread to other organs like lung without lymph node involvement in the neck? To be honest, I don't find that happening often at all. I can, I'm not someone who tends to say never or 100%, but it is, this is one case where I have not seen that, because it's just, it's got to pass through the lymph nodes before it gets to other places. So often, if there are lung mets, there was something in the neck lymph nodes that may be not appreciated with the first surgery, and there might be something there. The other question is, should distant disease be searched for if calcitonin and CEA levels are normal? So it seems like a straightforward question, and there could be a straightforward answer where the answer would be like, no. But it actually can be very complicated, because we do have sometimes where our patients, not often, but they're not good calcitonin or CEA producers. What I mean by that is we know that they had disease like in the neck with their initial presentation, and yet even at that time their calcitonin wasn't very high, and yes, maybe after this. So let's just give an example. A patient could have multiple large lymph nodes in the neck, up to 2-3 centimeters, and yet calcitonin is only 500. That seems a little discrepant to me. Typically, I would expect to see a calcitonin much higher, but it's not impossible. all. But even a better example would be if the calcitonin was like 50 in that situation. That's a little better example. And after surgery, sure, calcitonin goes down, but in that patient, I'm still going to screen for distant metastases. So, but if the patient had no evidence of lymph nodes clinically or by surgical pathology, and their calcitonin and CA truly are in the normal range or undetectable calcitonin, I am not searching for a distant disease, okay? And then what tests are best to search for distant disease? So kind of based upon what I said earlier in the talk is in patients where they do have lymph nodes, I will screen their lungs with a CT chest. MRI chest is not very good. CT chest is better. I'll screen their abdomen, especially their liver, with either a CT abdomen or an MRI of the abdomen with a liver protocol. This is to allow the radiologist to image the liver as the contrast is washed away with time. Tends to be that medullary thyroid cancer nodules are very vascular and they hold on to the contrast a little bit longer. And so we want to see that kind of timing fade out. And then after that, the MRI of the spine to screen for bone disease. Now, there was some people had noticed that they get the PET CT. So I talked about this, that the radioactive glucose PET or FDG PET is not typically the PET that I would do. If I saw that tumor markers are rising and yet my typical imaging with CTs or MRIs are not showing disease progression, that's when I would consider a gallium dotatate PET CT, okay? So that's that part about just kind of monitoring and looking for things. This other question was a person who indicated that had a total thyroidectomy 3 years prior. Multiple lymph nodes were involved. Actually, before surgery, calcitonin was 16,000, CA of 500. And the calcitonin dropped and now is around 300. CEA is around 10. And it's been stable. And this gentleman commented that he's had PET CT done twice and a bone scan, both clean. Again, I typically wouldn't be doing a PET scan or a bone scan because bone scan can be very insensitive at picking up bone metastases. A PET CT can be insensitive because if lesions are small, it won't light up, or sometimes medullary thyroid cancer won't absorb the radioactive tracer for that PET, and in that case, it won't light up. So I really stick with good, old-fashioned, but very good ultrasound of the neck. That's the best way of picking up disease recurrences in the neck. If something is seen on the ultrasound, I might sometimes do a CT neck just to look up higher behind the jawline or down low behind the sternum. CT of the chest, at least with someone with a calcitonin of 300, I would want at least one CT chest to ensure that I don't see any small lung nodules. If there are lung nodules, I will continue to follow that. And then MRI of the abdomen. So I wouldn't be imaging with PET CT. Now, the same person did say that there are 3 lymph nodes that look suspicious that was seen on the PET and the ultrasound. And the question is, should he have these removed? And if he does, would the calcitonin drop to normal? So the answer to whether if they should be removed is it all depends upon the location. If they're small and off to the side and they're not growing, then we would not necessarily remove them. But if they are in locations like near the airway or the esophagus, and if they do grow, they have risk to those regional areas, then maybe we do operate on that. Before operating, I would do an ultrasound guided biopsy to prove that one, if not other lymph nodes are truly diseased. We never operate just because we see a nodule. We operate because we know it's disease, not suspicious for, we know it's disease. And if these lymph nodes are removed, will you get cure? No. You will not get a 0 calcitonin. You will not get a 0 or a 2 CEA. I just have to be realistic. Just because those 3 lymph nodes are there and they're suspicious, and let's just say for argument's sake, they truly are disease. By removing them, there are likely microscopic cells elsewhere in other lymph nodes or potentially other areas like lungs or liver that just are not radiologically appreciable. So when we operate on the neck again, and I shouldn't say we, when our surgeons operate in the neck again, it's really not to lead to cure. That's not the goal. The goal is to prevent badness from happening in the neck down the road. So if it's disease in locations that could threaten trachea or esophagus or recurrent laryngeal nerve, that's when we might prioritize surgery. It is not the goal of getting biochemical cure. And this is a segue. It's not a question that people ask, but I do say this to a lot of my patients. The calcitonin and CA, they are just numbers. They don't hurt you. What they do is they give us an insight on whether we need to do anything else, like imaging or doing extra imaging or another special imaging to make sure that we're not missing the trees for the forest, meaning that we find the other areas that potentially have disease that might be slowly progressing, and then we will follow those. And if there's enough progressive rate, then we might consider treatment in a dedicated fashion. So again, I know that there's so much anxiety around what your tumor marker is, and oh my gosh, it's rising. But the tumor marker is not the thing that's causing harm. What is causing harm is potentially the tumors. And that is what we need to evaluate for. And the markers help us know whether we're doing the right imaging, if we need to add on any imaging, okay? Then there's, I have about 4 other questions that came through from the last session. This one was about a patient, a person whose daughter has MEN2B, and has followed with one of my excellent colleagues, Dr. Wagaspak, and wanted my opinion on whether I agree with watching, because unfortunately she does have evidence of disease in lungs, liver, and bone with a calcitonin of 1800 and a CA of 79. She has no symptoms, and these are all stable. Her tumors are stable. So my first answer to that question is I will never argue with Dr. Wagaspak. Dr. Wagaspak is a brilliant clinician and investigator, and you're in good hands with Dr. Wagaspak, okay? So number 1, reassurance. Number 2 is I would do the same thing. I would watch. Why do we not give chemotherapy when things are stable? So tumor markers are present and maybe even progressing a little bit, right? But tumors are stable. The reason why is all of our chemo drugs, the 4 drugs that I briefly touched upon, they all have some side effects. And although the RET inhibitors are a lot milder than the cabozantinib and vandetanib kinase inhibitors, there are some side effects. It can lead, we could see hypertension in 20 or 30% of patients on selpercatinib or pralsetinib. We can see a decrease in white blood cells, specifically lymphocytes. Right now in this COVID pandemic, you need every white cell that you can get to fight off infections. You don't want a low lymphocyte count, and then you can't fight off viruses. And it can lead to liver enzymes being abnormal because of some liver inflammation. So there are some side effects. And although most of our patients say, I feel great on this RET inhibitor, so much better than when I was on Cabo or Vandy, there are things that your oncologist needs to follow and monitor for potential risk. And none of these drugs offer cure. So Cabo, Vandy, selpercatinib, pralsetinib, none of them are curative. They can shrink disease down to where calcitonin and CA looks normal and lesions look tiny, but the cancer is still there. And unfortunately, if you do stop drug, they can grow. And that is a segue to another question that said, if by chance you're on a drug, kinase inhibitor or something, and you go off of it, will the disease come back at a more aggressive pace? Not necessarily. It could, but not all the time. And how do I justify that? Well, I've had patients who have been on vandetanib or cabozantinib for a prolonged period of time, and their lesions got down to very, very small lesions, and they had what I call drug fatigue. They were tired of the side effects, right? And just living with a little bit of nausea, a little bit of dry mouth, a little bit of irritation on the skin. Maybe they can still work, but it's a hassle, right? And totally understand. And so in some of my patients, I have done drug holidays, but I have an agreement with my patient that I'm going to see you regularly. I'm still seeing you every 2 to 3 months with imaging, because if things grow, we start drug again, right? But in some of my patients who stopped drug, I did not have this quote unquote explosion of their disease. I've had a few that has happened, and some of my colleagues have had that happen. So if we don't want to stop drug if it's working and you're tolerating it. But if there is enough shrinkage of disease and it's really minuscule now, and you just kind of want to do a drug holiday, I'm willing to have that conversation as long as we're still able to continue to monitor closely. It doesn't mean, oh, we're stopping drug and see me next year, right? It's we're stopping drug and I'll see you in 2 to 3 months with repeat imaging and see how we're doing. So going back to why it's okay sometimes to not start drug is so that we're not having to do all this monitoring for side effects and everything, but also and this is more of a hypothetical and not, and I say this very carefully. It's not impossible that sometimes when people are on drug therapy, that there can be resistance that develops even while on therapy. Now, is resistance because of the drug, or resistance because, well, there was going to be those cancer cells in the background that are resistant to the drug and they're going to progress down the road? We really don't know. And so, but we have had some patients who have been on the RET inhibitors and did really well after 2-3 years, but starting to have some progression. And when we recheck tumors for mutations, there's a new mutation, either a new mutation of a resistance mechanism like a RET810 or a RAS mutation, and it puts the patient at resistance for that RET inhibitor that they're on, in which case then we need to think about a different RET inhibitor for the patient, or potentially going to cabozantinib or vandetanib, the drugs from over a decade ago. So this is all theory, but if patients need drug, they should go on to drug. And need drug is if they are having progressive tumors that are at a pace that is concerning and could threaten our patients' well-being. That's when we would think about chemo drugs. But we wouldn't do it just because of tumor markers being present. We wouldn't do it just because tumor markers are slowly rising. I have a great example of a patient who saw me when he was in his early 50s, because he presented at an outside hospital with severe back pain and found to have a large tumor in the spine that was pressing on his spinal cord. And he went for surgery because otherwise it would lead to paralysis eventually, and he was in pain. The tumor was found to be medullary thyroid cancer in the bone. And so he was referred to me and Dr. Libby Grubbs here at Anderson, and he had a tumor in his thyroid and multiple lymph nodes in the neck, and some small little spots in the lungs, but they weren't too major. But actually in the liver, we saw big spots up to 3 centimeters in size. And so he underwent thyroid surgery and lymph node dissection. And at that time, you know, this was around 2000 and around that early 2010, 11 timeframe. And we already had vandetanib already and cabozantinib in clinical trials. And his question to me was, do we start chemotherapy at this point? And I said, actually, no, because this could have been here for years before it was finally found, right, and caused you symptoms. And so I monitored him and I saw him every 4 months for the first couple times. Then we stretched it out to every 6 months for the first 2 years. And then I was watching him once a year, and tumor markers were slowly creeping up, but imaging, nothing was progressing. Even those liver mets were totally stable. He has seen kids graduate from college, get married, and have grandkids. And it wasn't until year 11 after me following him that he started having some progression. And because he has a RET mutation, we put him on a RET inhibitor. So, the patient had 10, 11 years without any chemotherapy, without any need for a close follow-up. He was busy, he was working, he was traveling. He didn't want to see me every 3 months, right? So I wanted to emphasize that sometimes quality of life is also letting things kind of not being so hyper vigilant about the disease. So then there's the other question. Hopefully that answers the question of why we don't always start chemotherapy, just even in the presence of tumor markers being present or even lesions being present. Are there pros and cons to reducing the dose of Retevmo or selpercatinib? So this is very, very specific, but this says that the family member was started on the maximum dose, 160 milligrams twice a day, and there was some response where lesions decreased. And after 2 years, CA calcitonin continued to decrease. Is it conceivable to reduce the dosage and keep the disease in check and being less hard on the body? It's an excellent question. And that is a question that has been in my mind since the beginning. What I will say is if your family member is on the drug through the clinical trial, and if the patient has been on it for 2 years, more likely than not, they got started. Well, they could have been started in 2020, I suppose. So after the drug was approved. So that being said, if they're tolerating the full dose and it's working, we would not change anything, no reduction. But certainly we've had patients where they've had high blood pressure and the blood pressure medicines didn't control it. So we had to drop down the dose, or their white count dropped and it was seriously low. So we had to drop the dose. So at times I've had to drop down to even half dose, 80 milligrams twice a day. And I've had patients on 80 twice a day for over 2 years with still control. So will a lower dose still control disease? Yes. Will it control it as well as the 160 twice a day? I don't have data to support that. The trial ramped up pretty quickly to the full dose 160 twice a day, pralsetinib 400 milligrams a day. So we don't have those data on comparison at lower doses versus high doses, but I can conceive that patients can do well on lower doses. That patient that I said with 11 years of no chemotherapy, but recently started on selpercatinib, he had high blood pressure. He's on 80 twice a day and doing very well for the last 2 years on that one. So, so I wouldn't reduce dose if he's tolerating it and everything is stable and no organ dysfunction. Okay, now this one is interesting. This has to do with imaging frequency because people are concerned about radiation associated with CAT scans, and I get that. But to be honest, I've had patients on drug therapy for 5-10 years, and we're doing scans every 3 to 4 months for the first 3 years, and then eventually we start stretching it out, and yet they have not had any other cancers develop. So I think the concern that other cancers can develop because of frequent exposure to CAT scans is definitely a concern, but we just haven't seen it. And I've had some patients on chemo drug for longer, 10 years, and we're monitoring their tumors with CAT scans. Now, that said, I convert to MRIs whenever I can, or do ultrasound whenever I can. So if I need to do a CT neck, I need to do the CT neck. But like if there's tracheal wall involvement and I need to make sure I delineate that, ultrasound is not good for distinguishing that. But if it's just lymph nodes and they're relatively stable, I might only do ultrasound of the neck to monitor. CT of the chest, like I said earlier, it is the best imaging modality for the chest. X-rays are not going to be very informative. MRIs are not very informative. So, but at the abdomen, if I know that they have liver lesions, I might do a CAT scan the very first go around, but to follow, I might do MRIs because it's a magnet. There's no radiation. Same thing with bone. I like to do the MRI of the spine for that one. But there was a question saying, asking if many CAT scans, or is there validity that many CAT scans can cause a mutation that causes the cancer to be resistant to the kinase inhibitors? That I have not heard of. That would not be the case. I'm not worried about that. I think more people than not are worried, does the radiation put you at risk for other kinds of cancers? Now, there are some patients who have certain tumor syndromes that are that they might be at risk for other cancers, not the MEN2, but there are some patients who can have, it's called leaf-Romani, and they can have other cancers of the breast, the muscle, the bone and everything. And those patients, if they do get overexposure to radiation, they might be at a higher risk for it. So we take that all into account, but most of the population should not have any significant issues with that. Okay, so Daria, those are the questions that I had gotten from that first session,
Right.
and that
And
already took
lots of
26 minutes.
questions.
Yeah. Okay. So
there's a really interesting one that says, when is the time to start the bone strengthening injections for patients with bone mets?
perfect. That's a great question. Like I said, about 20% of patients can have bone mets with the medullary thyroid cancer. I've had lots of patients where it's only predominantly bone mets. So it's a problem because our kinase inhibitors, whether it's Cabo or Vandy, and even selpercatinib and pralsetinib, they don't penetrate the bone environment very well. Why that is not overly clear, other than it's just how they kind of penetrate the circulation into the bone. The bone just has a very tricky, lots of cancers have resistant bone metastases to drug therapy. So if it's just one spot in the bone, I might, and it's stable, we watch. If it's one spot in the bone, but it is progressing, then we might radiate that one bone spot. Okay, but if there are multiple spots, and when I say multiple, there's no real tried or true number, but if I start seeing more than 3 or 5 bone lesions and they're progressing, then that is when I would consider the bone targeted therapy with zoledronic acid. The brand is called Zometa, or denosumab. The brand is called Xgeva. So Zometa is given as an infusion in the vein once a month, once every 3 months, sometimes once every 6 months. And I'll tell you how I do that. And then Xgeva is a shot under the skin once a month, once every 3 months, once every 6 months. These drugs actually are also used for osteoporosis. So these are drugs that have been around for a while. But how do I manage these drugs when my patients have multiple spots of bone metastases and they're progressing? How do I give the drug? So so I check something called a bone turnover marker called the CTX, collagen telepeptide. It's a blood test. Some people like the urine NTX. It's just different collagen breakdown products that can be measured either in the blood or the urine. And so if I'm thinking that I need to start someone on a bone modifying agent, I will get a CTX at baseline. Then I treat them with either Zometa or Xgeva, depending upon the situation. And then I check that CTX level 1 month or 3 months afterward. And I hope to see that the CTX drops. And if the CTX goes down, that means the drug is working, it's inhibiting bone breakdown. And in which case, I might time the next dose based upon when I start seeing the CTX climb up again. Okay, so that's just a broad stroke recommendation, but it gets to be a little more fine-tuned and complicated than that, but that just gives you an idea of things that I think about. Okay, what next,
So
Daria?
there's lots more questions.
I could just start at the top if you
Yeah, I
want.
would just start at the top and work your way through.
Okay,
because
great,
I'm
great,
not seeing
great.
a ton of, I'm not
Yeah,
certainly not an expert,
okay.
but I don't see a ton of correlation.
Okay, so yes, so I addressed Miss Ann's question about the bone strengthening injections.
Yes.
Mr. Drayton, so the question is, since there are no systemic treatments having curative intent, I understand the desire to not cause more side effects than the patient already has, but is there a fear that a systemic treatment kills, say, 95% of metastases, that the last 5% could be more aggressive, and now that it has access to blood supply, it will propagate? Yeah, this is my hypothesis, is that cancer cells in our body is not always homogeneous. Like, although the idea of cancer is that it emanates from one cell that became abnormal, got a mutation, and that mutation is propagating that cell. Yes, the majority of tumor cells will have that same fingerprint, okay? But cancer cells, the reason why we have not been able to just knock it out of our world is because they mutate, and with every mutation, they can take on other mutation. With every division, they could take on other mutations, and those mutations may still be abnormal, causing the cell to be abnormally cancerous, but maybe not as aggressive, or may not be able to get access to the nutrients to survive, because Big Brother, with the representing the 95% of the population, is very active in hogging all the nutrients, right? So the idea is, yes, if you start chemotherapy, you're probably targeting the majority of the cells that's going to respond to the drug. And then now, is there this quiet little population of cells that says, hey, Big Brother is gone, I don't need to fight for food, I can just take it all in, and now they're nourished and grow. So it's not so much that they are more aggressive as much as maybe they now have access to nutrients that they didn't have access to before. Now, it could, hypothetically, can there be cells that have acquired a mutation that does make it more aggressive? Absolutely. Certainly cancer cells can do that. We see that with anaplastic thyroid cancer, where they have like multiple mutations, and it's making these cells just not listen to any regulation by our normal body's regulatory pathways, and they can be more aggressive. So yes, these cells could just be more aggressive and now have the opportunity to grow. So hopefully I addressed that question. Okay, this one is a great question about molecular testing. So Miss Susan was diagnosed in 2007. She knows she has sporadic thyroid cancer. Her tumor wasn't tested at that time, probably because we just weren't doing that regularly at that time. Were we doing it at Anderson? Yes, we were, but are lots of other places? No. So can it still be tested for a RET mutation? So first of all, I would step back. Does it need to be tested for a RET mutation? Okay, or any mutation? It depends upon your situation. If you have no evidence of disease, or your disease is very smoldering, maybe tumor markers are present, but they're not rising too quickly, or tumor markers are very, very low, and you know that there's some lesions, but the lesions are not progressing, I wouldn't necessarily check for a RET or other mutation. I tend to recommend checking for mutations. I'm not just going to isolate it to RET. I'm just going to say mutations. When I see tumor markers are rising, even if imaging is not showing a lot of change, but if tumor markers are rising, I kind of want to set the stage. I want to understand the biology of the patient's disease. So I know in the future, when we see tumors progressing, I can pull out this particular drug because I know you have this mutation, okay? But certainly if tumors are increasing, I'm checking for mutations. In patients who do have a lot of metastatic disease, even if we don't have any establishment of pace of change, I might check a mutation because I'm thinking that sometime down the road, there will be progression and I might as well get it on your tumor that we have fresh right now. That being said, tumors typically are stored in pathology labs anywhere between 5 to 10 years. So 2007 is a little bit remote, and even at Anderson, that 2007 specimen would be discarded. We keep our tumors for 10 years after resection at Anderson. So it just depends upon what the pathology lab has. So probably that specimen is not available to be tested. Now, if you did have a tumor that was from 2017, so 5 years ago, then it might still be viable and available. Tumor that gets older, over 8 years in the freezer, does degrade and sometimes cannot be analyzable. So we tried, but it may not be analyzable. But my patients who have evidence of progression, and when I say progression, I mean tumoral progression, not markers, just tumor progression, we tend to want to do molecular testing on that progressive lesion because your progressive lesion may not look like the lesion that was removed 10 years ago. And maybe in 10 years, you have acquired some additional mutations. So it's actually better to do molecular testing for mutations on a more recent specimen that might have been progressive or resected. Okay. Okay, so I think that Mr. Brian, you sent me those questions. I hope I answered those. Yes, I did answer all those. And then Saba A, lung mets have grown from 3 millimeters to 6 millimeters in 6 months. If I wait until they get to 1 centimeter to start TKI, do I run the risk of more mutations or more resistance to drugs? Not necessarily. I've had, like, for example, that patient of mine who diagnosed 11 years ago with that bone met, I knew he had a RET mutation from then, yet 11 years later, he's responding to the RET inhibitor. He didn't have any, but I did, just so you know, I did recheck to see if there were any new mutations before starting the RET inhibitor, and there wasn't any. So the short answer to your question is no, we should not worry about resistance developing in this period of time or waiting until lesions really need to be addressed with systemic therapy. Vandetanib, okay, thank you. So vandetanib has been paused. I wouldn't use the word discontinued, but it has been paused by the manufacturer, and what is recommended to replace this drug. So this was one of the questions I was going to raise if it wasn't raised by the attendees. This is a problem. This is a supply chain issue. This has to do with the whole unfortunate situation with the COVID pandemic, leading to staffing shortages, leading to manufacturing company shutdowns, and even just buses, trucks and trains delivering things. So but I don't know the exact details. All I do know is that the manufacturing location is slowed down, and that's why the 100 milligram and the 300 milligram dosing over the last year, there's been some times where they didn't have the 300, but we have 100. So then my 300 patients, they had to do 3 of the 100s for a period of time. And then the 100s were gone and we only had the 300s. So my patients who are doing 200 milligrams a day, I had them do 300 on day 1 and day 2, but nothing on day 3, and to give them 200 milligrams on average. We had to do math, creative math to help our patients get the doses that they wanted. But this situation is a little more concerning and serious in that they informed us that they weren't going to have pill supply until October for 1 dose and then November for the other one. And so I've had to have discussions with my patients on either their disease was so well controlled, we kind of stretched out their supply with the vandetanib I had them do every other day, so that their supply of 30 now stretches out to 60 days, while we can stretch them out to their next shipment to be sent to them. But some of my patients who have been on, say, vandetanib for the last I have one who's been on it for almost 5 years, another one for 10 years, 11 years. They both had RET mutations. And actually, when the RET inhibitors came out, I did have that discussion. Do you want to switch over to the RET inhibitor? And both were like, it was a love-hate relationship, but now I know my drug and it knows me. I don't want to change because things are stable, right? They didn't want to rock the boat and they felt very comfortable with their drug. But now we're having that conversation again, is maybe we need to think about switching you over to a RET inhibitor now that we know you have a RET mutation. Now, if they don't have the RET mutation and we are getting to a point where they can't half the dose of their vandetanib, we are recommending change to cabozantinib for those patients. And so that's what we're doing. Now, if the patient does not have a RET mutation, we can't put them on a RET inhibitor, right? It's not going to address their mutation, so it would not be effective. Okay, hopefully that helped you, Miss Patty. Now, my tumor was found incidentally on a chest CT, which was done for follow-up with these lung nodules, first noted in 2019. What's the likelihood that the lung nodules represent metastatic disease, given that there's no nodal involvement on the ultrasound and all is negative from the surgical resection? Well, first of all, I guess I would ask the question of, are your tumor markers undetectable? If your tumor markers are undetectable and your lymph nodes were negative, I would feel pretty comfortable saying that those lung nodules are not likely metastatic disease. That we breathe everything in the air into our lungs. When we get dust particles, your work environment, we get bronchitis, you can get these little scarring things in the lungs, and they show up as little nodules and they're benign. So if lung nodules are not progressive and your tumor markers are undetectable, I would feel comfortable saying that this is not metastatic disease. And if it's been followed since 2019, now 3 years, we tend to stop following the lung nodules. If tumor markers start rising, I will re-look at those lung nodules and see if over time they are actually changing. Medullary thyroid cancer is so indolent in so many patients that these lung nodules could be metastatic. I'm not saying these in you, ma'am, but lung nodules could be metastatic and they don't grow, like they don't show their true colors for 6 years. Like I've thought, I'll do that where I follow for 2 to 3 years, everything's stable, I stop, but eventually 8 years later, I notice tumor markers rising and I do another CT. Then they're like, in retrospect, compared with 5 years ago, the nodules have increased. Not a lot in 5 years, but a little bit of increase. So now it's telling us that it's metastatic disease. So I think that in your case, ma'am, if you don't have any detectable tumor markers, I would feel comfortable saying that those lung nodules are probably incidental. Okay, if they keep on more and more. If on Retevmo, what level of hypertension is acceptable before treating the hypertension? Are there certain hypertensive drugs? Wonderful question. Is the top number, the systolic number, is consistently over 145, definitely if over 150, I'm thinking about starting drug. The lower number, the diastolic, if it's over 90, I'm starting drug. And what do I start? I usually start what's called an ACE inhibitor or a angiotensin receptor blocker or an ARB. These are the ones that are kind of called prils, lisinopril and losartan. Why? Because they actually have a little bit of kidney protection. They also have some protection against heart failure, and they work. So I do that because also it doesn't affect the heart rate. At times, I might consider a calcium channel blocker like amlodipine. Sometimes if their heart rate is high, over 80, then I might do metoprolol. So there are a lot of different antihypertensives, but my first go-to one will be an ACE inhibitor or an ARB. Okay, been on Caprelsa for 14 years. First of all, Miss Susie, congratulations. That is wonderful. But you are talking about the medication won't be available until late December or January. Calcitone's going up slowly from 500 last year to 1800, and CA is 2.7. Decided to wait until the medication becomes available. How do I know if that's the right decision? I don't know if you can actually answer that. I'll be doing CAT scans. Okay, so I think I can answer this very quickly, similar to the question that I had earlier about what to do about drug therapy. I think in your situation, Susie, is if you're completely out of drug, it just depends on how your imaging is. If things are, I mean, tumor markers will rise when you stop drug. That just happens, okay? Again, don't let the tumor marker raise the anxiety level. It's really what are the lesions doing. So if lesions are increasing, maybe you do need to consider a switch to either cabozantinib or to, if you do have a RET inhibitor, maybe a RET mutation, maybe a RET inhibitor. How often do I see patients that have their vocal cords removed or can't breathe anymore by themselves? That's one of my fears. Oh, I know. So typically vocal cord injury happens because the tumors are so big that they're wrapped around the nerve, or a surgeon had to sacrifice the nerve because they were dissecting the tumor and they just could not get it off of the recurrent laryngeal nerve. But it is not that common. But honestly, I have seen it. It typically has been in patients who kind of ignored their symptoms. Like they had hoarseness for 3 years and finally their wife told them, you need to get that looked at. I'm sick of hearing you like this, right? And unfortunately it had progressed enough to that point. So honestly, Miss Lizette, for your question, I don't believe that's it is a risk. But I think in the hands of a good surgeon who's experienced and has high volume, the risk should be as low as possible. And remember, we do have 2 vocal cords. So even if one is knocked out, you still have another one. I'm not trying to be cavalier, but people can do well with one functional vocal cord. They do notice voice weakening and maybe a little choking on liquids, but we have also vocal cord specialists who can do injections in the vocal cord to stiffen it up. So I wouldn't let the fear of the vocal cord injury prevent you from getting the treatment that you need, okay? Any correlation with thyroid and breast, not with medullary. I can answer that one very quickly. Any correlation for excessive tearing with MTC diagnosis, not allergy driven? No, I have not heard of that. That's interesting. Now, certainly we've seen that with papillary thyroid cancer patients who get a lot of radioactive iodine. It causes tear duct abnormalities and they don't drain their tears well, but I don't hear that very often with medullary. So I'm sorry about that. And thank you, Mr. Drayton, for validating my answer to you. What impact does the drug have on future pregnancies? Very good question. We recommend not getting pregnant when you're on chemotherapy. These drugs will cross the placental barrier and it can lead to severe potential fetal abnormalities. We don't know. I've never been in that situation, thank goodness, but we always, in my childbearing age women, while they're on chemo, I'm checking a beta HCG, I'm checking for pregnancy tests each time. And I hope that's always negative, right? But my patients know not to get pregnant when they're, and even for the men, not potentially getting someone pregnant, right? So practicing barrier method or contraceptive use. So I will tell you that I actually had a patient who, her goal in life was to be a mom. Okay. And she, when I told her about her cancer is growing, it was devastating because I was talking about chemotherapy and everything. And she's like, but I haven't had my baby yet. And I said, I know. And she said, let me do this. Let me have my baby. And I said, I didn't know you're married. And she's like, that's okay. But she was in a relationship. Okay. But I thought that was kind of an amusing response. That's okay. That won't hold me back. But she does have a baby. And after she had her baby and breastfed, so it was a year and a half, We knew she knew, eyes wide open. She knew she had disease, and after she had her baby and breastfed to what she wanted to do, we started vandetanib in her, and now that baby is 8 years old and causing a ruckus on those video visits in the background and everything. And so, I recommend that if pregnancy is a desire, that you either bank your eggs or do embryo, collection. It's expensive, totally get that. Or try to maybe consider a little earlier timeline for you compared to with another situation. For men, it's a lot easier. They can sperm bank and hold on to their sperm before exposure to chemotherapy. What advances in treatment are you seeing now or expecting to see for those with a KRAS or HRAS mutation? They're still waiting for this miracle drug. Absolutely. So I tell my patients that I almost wish that you have a RET mutation because at least I have options. Whereas the RAS mutated patients, it's still vandetanib and cabozantinib. So that said, there has been some advancements, and I just went to a meeting in Paris, the European Society of Medical Oncology meeting, and also ASCO earlier this year. There is a lot of interest in it. That being said, it's just, and I can't explain why in this session. It's really beyond me. I need a basic scientist to explain it. But RAS mutated tumors just historically are very difficult to target with drug therapy. And so we have to be creative. There is a particular KRAS mutation. So it's very specific. You need to know which one, but it's a particular subtype of KRAS that there is a drug that has gone through phase 1 trials that has been effective. But most of our patients don't have that particular KRAS mutation. So I know, pretty insert your word that you want to use, but it's pretty lousy situation. But I do think that there some advancements I think are, and I've said this before, that immunotherapy doesn't tend to work by itself. So Keytruda, Opdivo, we have some early indication that just single agent immunotherapy does not work. But could it be helpful if it's combined with one of our kinase inhibitors like Cabo or selpercatinib or pralsetinib? Who knows? Something worth us investigating. It could that there be any potential with CAR T therapy. So I say this gently because I know the attendees, they've asked me about CAR T and everything. It's still very, very fresh and novel therapy for solid tumors. It's been used for liquid tumors like leukemias very effectively. And that is just a nuance of the kind of cell that leukemic cells tend to have one type of expressed protein on their cell that's not expressed on liver, heart, other vital organs. So they can actually engineer the T cells to recognize that one receptor, that one protein as being abnormal and target it specifically to that patient's leukemic cells. The problem with solid tumors that come from typically epithelial cells or like our neuroendocrine cells, a lot of the proteins that are expressed are also expressed by normal cells in other parts of our body, other organs. And so when you do that CAR T, you could potentially affect other organs. So that's why it's hard. But that said, and my colleague, Dr. Cabanillas, this morning just gave a talk on anaplastic thyroid cancer. At Anderson, we actually do have a trial going on using CAR T, but for poorly differentiated thyroid cancer or anaplastic thyroid cancer, not for medullary. And this has to do with the fact that they're looking for if the cells have this particular protein on the surface. And they found it with anaplastic or poorly differentiated, not so far with other tumors. So that said, I say this gently because I don't want everyone starting to ask me to get enrolled onto that trial. It's not available to MTC right now, but Are there advances? Yes, I do think there are advances. And I've been so lucky and privileged to be in this field, starting out when I was a lowly little fellow and naive to this world. But I've been able to see so much advances in this world. It's just been amazing. One more question.
I do want to
Yeah.
point out that we have about 7 minutes left.
Yes.
And you do have a nice notes in the chat from a Sandy saying that she's looking forward to seeing you in January. And pickleball Todd says, Doctor Who, you're my favorite doctor.
You guys are so awesome. You guys are, oh, thank you so much. Actually, Mr. Todd, just so you know, my other patient who was the first one to tell me about pickleball and its amazing aspects of pickleball, I saw her today and I was just talking with her about pickleball, and I mentioned you telling me that out of all the sports you've done, pickleball has been the best out of even amongst all other sports. So that's great. Okay, and thank you so much.
Maybe a quick question. Any correlation between MTC and renal cell carcinoma?
No, that's another good question. I have seen some patients with metastatic lesions to the kidney, but I have, but that's rare, very rare. So if we see it, we sometimes do recommend biopsying it. But I do have a few patients with medullary and renal cell, and but they're not a lot. So and we have not had any correlation like genetic mutations or anything like that. I think it's unfortunate, it's just coincidental.
Another short one says, would you consider radiotherapy of the neck after a modified radical neck dissection in order to kill any microscopic cells left?
100% no.
No.
100% no. And the longer answer is that radiation causes a lot of scar tissue. It can cause a lot of scarring of the trachea, the esophagus. And then now 10, 15 years later, you're not swallowing food well. You need dilations of your esophagus. That could cause a perforation. Once you get radiation, that scar tissue buildup, it almost closes the door for future surgeries. And here's the thing is, although we have data to support, and this was from old data at MD Anderson even, that radiation does decrease risk of neck recurrences, it is not worth the risk of the side effects of esophageal strictures and potentially fistula formation, because the reality is that there likely will be a recurrence, whether it's in the neck or elsewhere in the lungs or liver, and we might need to start you on chemotherapy down the road. And if you have a RET mutation, we might put you on a RET inhibitor, and that doesn't have as much risk for perforation. But if you don't have a RET mutation, you're put on Cabo or Vandy, there is risk for starving blood flow to even normal organs. But if an organ is injured because of radiation scar tissue, you give them a anti-angiogenic like Vandy or Cabo, there's a high risk for fistula formation, a hole developing, and in which case that can be catastrophic. And so just because there was burdensome disease in the neck, we do not recommend radiation. Now, if there's involvement of the tumor of the tracheal wall or the esophageal wall, and my surgeon operates, and he said I could get most of the gross tumor, like the obvious tumor that I can see with my eye, I got rid of, but there's microscopic disease. I had to shave and there's microscopic disease. Then maybe we will do targeted radiation to that field where there are likely microscopic cells left, because we don't want that to progress and cause invasion into the trachea or the esophagus. And this is not just medullary, this is papillary thyroid cancer, Hürthle cell cancer as well.
Okay, we've got 3 minutes. How long can I be on Zometa? I was having infusions every 3 months for 2 years. My doctor had me stop because he said it can be bad to continue after 2 years.
Yeah. So too much of a good thing can cause problems. So there is a rare risk of something called osteonecrosis of the jaw in patients who get Zometa or Xgeva once a month, once every 3 months, for more than typically 6 doses. There is a risk for this osteonecrosis of the jaw, 1 to 3% of our cancer patients. And this is breast cancer, lung cancer, colon cancer, and medullary thyroid cancer patients. So that's one of the reasons why I use the bone breakdown marker, that CTX, to guide the frequency. So I like to give, if I have to give it, I'll give it, but just at the amount that we needed. So if I could give a patient Zometa once every 6 months, and this is over 4 years, and now they've gotten 8, then they've gotten the right amount, but not excessive, rather than once a month for 4 years and get potentially 48 doses, right? So, so I guess the issue is that it depends upon what your bone lesions are doing. If they are stable, I might consider a drug holiday and then monitor and see how things are going. Okay.
So we have 2 minutes left and there's 2 questions left. I don't know that we're going to be able to do both, but one of them might be quick. Just started a drug I can't pronounce, lepercatinib.
Selpercatinib.
It says that they should wear gloves. Is it really necessary when they're handling the drug?
Yeah, interesting. Honestly, I was not aware of that. I don't think so.
So maybe a question for a pharmacist.
Yeah, maybe. Yeah, interesting.
And,
but the question about antacids, yes.
Yeah,
so
antacids.
So selpercatinib is dependent upon the pH of the stomach, the acid amount. And if you drop the acid amount, you may not be metabolizing the drug properly. And so basically lowering the dose. So what we always recommend is that if you really need to take an antacid, you should take it separate from your selpercatinib. And if you can delay at least like 4 hours after your selpercatinib, that would be better. Okay.
I don't think we're going to be able to get to the next one from Richard because it's fairly long.
Okay.
But I will take a screenshot of it and maybe we'll be able to do something offline.
Sure. Oh, actually, I can look at it really quickly, but yeah, so I probably would watch at this time. Yeah. All right. Well, it is top of the hour. It's a Friday afternoon. You all need a drink or whatever will make you happy this evening. But thank you, Daria, for facilitating, and Jim for the tech support, and everyone for showing up on a Friday afternoon.
Thank you for this wonderful presentation. We really appreciate it. Everybody, thank you. We'll see you around the conference.
Y'all take care. Bye.
Take care. Bye-bye.